Hello colleagues. Here comes part 3. And also the last of the highlights for Cardiometabolic and Venous Diseases Forum.
Here, our experts discuss angina, including its definition, types, tests, and treatments.
Hello everybody. This section is related to physiopathology and treatment of ischemic heart disease. We are very fortunate to have with us Professor Andreotti, the chairman of the working group of myocardial ischemia, and she will address the highly topical issue of microvascular angina, or angina without epicardial obstruction. So, Professor, what are your views on defining, diagnosing, and treating this form of angina?
Now, in my view, I may be wrong because, as I said, I'm more a thrombosis person from my background. We may be able to improve yet further in trying to introduce a unified hemodynamic abnormality that characterizes every patient, INOCA, INOCA, resistance, flow reserve, etc. And that is coronary flow capacity, which is defined in a very, by Lance Gould, also in a seminal paper that goes back several decades, but also here, as maximal absolute flow in the myocardium, plus coronary flow reserve capacity. So this is, can we measure this? Yes, we can, because we're used to measuring coronary flow reserve as the delta between hyperemic and baseline. And flow, we can measure it by velocity, because flow is not only pressure divided by resistance, but also is velocity times the cross-sectional area. So if we have the diameter of the vessel and the velocity, we can stratify capacity, flow, coronary flow capacity into these areas that do have prognostic meaning, and I believe might represent an important step forward. Diagnostic approach. Mani nei capelli, I would say, because this is my approach. Then, okay, diagnostic approach. So the accurate, precise, modern diagnosis of microvascular disease is based on these 3 items, the combination, because we said coronary flow reserve might be normal, but you might have increased resistance. And this is another item that I think is similar. Here are the abbreviations, and they are specifically reflecting microvascular indexes, or once you've excluded FFR, epicardial component, you can attribute CFR to microvascular disease. What are the steps that are advised in a modern diagnostic algorithm? The first step is to exclude flow-limiting epicardial disease through traditional angiogram or even through non-invasive CCTA. The second step is to assess microvascular disease or not, and the third through coronary flow reserve and IMR. But then there's the third final step, that is acetylcholine testing for vasomotility at different levels and at different doses. Basically, you start with low dose acetylcholine, and if you have an entirely normal vasculature, you're meant to vasodilate. If instead you vasoconstrict with low dose, you're entitled to diagnose endothelial dysfunction. At higher doses, you go into a range of vasospasm or vasoconstriction that may be epicardial, but we're not interested here because we're talking about microvascular, or maybe a constriction of the microvasculature, which entitles you to define microvascular abnormalities. So trying to put these together, we now have at least 2 big endotype chapters. We have coronary macrovascular disease based on the CFR and IMR, and then we have vasospastic microvascular angina, basically based on acetylcholine, although not specified here, surprisingly. Now, is it worth going through all this hassle you know, there are some, we heard Professor Rosano say, you know, let's not revascularize for everyone nowadays, partly because these procedures do have disadvantages and side effects. They have radiations, they have complications, the acetylcholine can induce arrhythmias, bradycardias, etc. We're beginning to see a bit of hard data that tells us that, yes, in terms of patient with persistent refractory symptoms that really has impaired quality of life, even in my view, and I'm not an interventionalist or an angina person since decades, if you go into the details and are able to characterize the endotypes, you're able to treat patients more effectively and to improve their quality of life. This was done in a rather small but significant randomized trial called Cormica. Now, if you really want to be critical, you could still say, I'm not happy because I've looked at one coronary. I've refrained from putting acetylcholine in the right because I may go into severe bradycardia. So what may be missing? Maybe the LED is fine, but I have microvascular dysfunction elsewhere. So some people sort of criticize the invasive coronary testing as being too regional and as missing a global coronary flow capacity, which indeed brings the non-invasive tests the most modern, like a positive emission tomography, cardiac magnetic, to the upfront, because they indeed have the capacity to measure all coronary territories and even to measure absolute flow, as we said, by PET, for instance. Now, is it apart beyond the quality of life of the patient, or am I really at risk if I have a chest pain that is considered of microvascular origin? This is a very much quoted paper, Giuseppe and al. It shows what? In blue, you have the normal asymptomatic normal coronary arteries. In yellow, orange, you have the normal coronary arteries. These are event-free survival or pretty hard endpoints. And you can see it's really very graded, because then in green, you have the diffuse non-obstructive, and then you have the 1, 2, and 3 vessel disease that in this paper, which is quite large, they're not significantly different, but I think we agree that it's a graded increased risk of MACE in patients that go from angina and normal coronary arteries to INOCA to 1, 2, 3, and vessel. I'm concluding, yes. This is the ELS registry that I meant to say, and the important thing here that I want to say is that those that had non-invasive testing that was negative, but yet had coronary microvascular dysfunction, had the worst prognosis according to this registry. Now, to conclude, the rest is related to treatment. I'm very happy that Professor Rosano went into the details. Here you find more, because unfortunately it merits a presentation on its own. Here you have all the possible combinations and mechanisms. Here you have the important concept of the comorbidities and perhaps some considerations. And these are my final slides. I believe in the future we have probably almost the duty to try to improve harmonization of definitions, epidemiology, and diagnostic protocols of microvascular angina. Consider realistically feasible diagnostic testing in global current clinical practice. Test innovative metabolic polypill treatments for microvascular angina with reproducible and meaningful outcomes. And these indeed are some trials that are ongoing.
Excellent presentation, Professor Andreotti. Our apologies for the time constraint, but I am sure that Professor Rosano will fully cover the pharmacological treatment of angina.
But if we look at all clinical trials that have been conducted so far, then there's never been evidence of a clear superiority of PCI of a medical therapy in terms of future cardiovascular events. And if we look at the recent Orbiter study that was conducted in the UK, where patients were randomized to receive a PCI or not, and but they were put asleep and they had a femoral puncture anyway. So you can see that patients had a certain benefit on angina. So there is a clear evidence on angina, but that was limited only to few subgroup of patients. So there's no doubt that the intervention is effective in improving symptoms. Whether that has an effect on prognosis is still a matter of discussion. These are the data from the ischemia study. You see that there was, at the end of the study, there was no difference between conservative or invasive treatment. And you may say that you have a benefit after 4 years, or there's a tendency to get a benefit over 2 years, but you pay the price at the beginning with an increased risk of events. So overall, there was no benefit on the primary outcome of intervention of medical therapy. I think that will put an end of the story that started with the Baritar trial, then went through the courage, and now with ischemia, on the difference between the intervention and medical therapy. And we can see that even if we look at hard endpoints like all-cause death, the two curves of medical therapy and intervention were superimposable. Now, and also, when you look at recurrent coronary events, so when you look at more than one hospitalization, you see that the risk of events is similar between intervention and medical therapy in the trial. So what is the treatment approach? And I think on that, all the guidelines for patients with angina, I think in that the guidelines are pretty much concordant. I mean, the ESC and the American guidelines, and they said that the initial management of patients with angina is medical therapy. Point is that they are similar, and in terms of prognosis, there's no benefit of one or the other. And that is, and then we have to individualize our medical therapy. Now, regarding medical therapy, I think that there's a major problem that comes from the guidelines, and that is mostly on the way guidelines indicate first line and second line medical therapy. And if you read through the ESC guidelines, they say that there's a preferred use of beta blockers because of their readily available and cheap. But if you look at the effect of beta blockers in patients with left ventricular function greater than 40%, there's no trials, no registries have, and this is just one of the many data on beta blockers that have ever shown that beta blockers improve survival in patients with ischemic heart disease. So in ischemic heart disease, there's clearly no single trial that has ever shown a benefit for beta blockers. Then we use the long-term nitrates with understanding that they work, but we transfer often what is written in the guidelines to chronic nitrates, because the guidelines give an indication for short-acting nitrates compared to the long-term nitrates are used widely in patients with ischemic heart disease, while we know that over time they have no effect on exercise duration and on anti-ischemic effects. Then again, I borrowed this from Professor Ferrari, who came with this brilliant idea a few years ago of looking at patients on as a whole and looking at patients with comorbidities. And I have to say that we also use that in heart failure, where we suggested a patient phenotyping. And basically, in this paper, he identified all the different possible causes of myocardial ischemia, and also separately also comorbidities. And you can see that patients may have microvascular dysfunction, they may have coronary vasospasm, they may have a fixed stenosis, and there are different indications of different treatments according to the different conditions. Because if you get a patient with vasospastic angina, there's clear no role for the beta blockers that may even increase vasospasm. And whilst for patients with left ventricular dysfunction, then there's a clear indication for drugs like beta blockers and ivabradine. And another important point is something we always forget, is the fact that if you use two hemodynamic agents together, they don't have any additive effect. So if you add a beta blocker to a nitrate to a beta blocker, or a calcium channel blocker to a beta blocker, there are 3 large randomized trials that have shown that the hemodynamic agents do not add any anti-ischemic effect. While if you use different approaches, you may get a beneficial effect. And these are data from the Associate study, where they looked at the heart rate reduction with beta blockers and ivabradine, and they clearly shown that the association of two different approaches in reducing heart rate has additive effect, as beta blockers and ivabradine are more effective. And this is, I think, is the best proof to show you that different agents with different mechanism of action have effect, whilst two hemodynamic agents do not work together. In this study, they took patients on beta blockers and they randomized them to receive either dinitrate or trimetazidine, that it works as a metabolic agent. So if you look at the effect of the nitrates, you see there was no effect of nitrates on the ischemic threshold on time to angina, so thereby confirming the fact that there's no additive effect of two anti-anginal medications, whilst when they added the trimetazidine, there was a significant increase in ischemic threshold and time to angina. And these are the data that have been analyzed by the Italian Institute of Health, and this is the first author is Cristiana Vitale, who's here. And there was on the VASCO study, there's the largest ever conducted study in angina, where patients receiving atenolol were randomized to receive trimetazidine or placebo. You can see there was a significant improvement in exercise threshold and ischemia with trimetazidine. And what was interesting from that study, and I think that is something that a company doesn't want to often to communicate, is the fact that we don't have a clear idea what is the top dose of the medications we can use, as the 140 milligrams was even more, it was more effective than the standard 70 milligrams. So 70 milligrams twice daily is even more effective. But the 70 milligrams, so the 35 milligrams twice daily, are very effective in improving symptoms. We have to understand that with metabolic therapies, we don't have the same immediate effect that we see with the hemodynamic agents. And this is true for all the metabolic agents, all the metabolic interventions. You see, these are the data with trimetazidine in patients who are taking all different sorts of combinations of hemodynamic agents. These were patients on beta blockers and calcium channel blockers, long-acting nitrates, combination of the three. You see, it takes a few months to get the best of the effect, but after 6 months, there's a very significant reduction in events. And that is true in patients with silent or symptomatic ischemias. We did demonstrate many years ago, where we showed that even patients that we thought were completely asymptomatic, receiving metabolic therapy with trimetazidine, had a significant reduction in the number of episodes for silent ischemia and total duration of ischemia. Then this was a study that we conducted just to demonstrate that you can switch patients who are on nitrates to get a greater effect, especially if they have to take a PDE5 inhibitor. So we took patients and we put a 24-hour ECG monitoring and asked them to have a sexual intercourse during the monitoring, and randomized them to have either trimetazidine or nitrates, and then we gave sildenafil to these patients. And you can see that there was a significant reduction of the episodes of myocardial ischemia. So despite having cheap drugs that we don't, they are not often acknowledged too much, then we see that and we thought back in the early 2000 that the metabolic approach could also have an effect on left ventricular function. And therefore, we pioneered the studies on in patients with heart failure using a metabolic approach with trimetazidine in this case, and many other studies followed. And I always like to show not one single study, but a meta-analysis, because if you look at the meta-analysis and the results are always on the same side, it means that the effect is very consistent. And you can see that in patients with or without ischemic origin, there's a benefit of in patients with left ventricular dysfunction on exercise capacity, on left ventricular function, and also on mortality. This is my last slide, and to say that our approach to patients with ischemic heart disease depends on the entry point, and that medical therapy and revascularization shouldn't be seen as either or, but should be seen in the normal life of patients with ischemic heart disease. You may have a patient that comes in an acute coronary syndrome and gets an immediate revascularization. PCI is life-saving in the acute coronary settings. And but then that patient will have to take medical therapy, and that will be for life, and they may require further revascularization for the quality of life. Then you may have other patients who come in and they receive medical therapy. They will be very well for most of their life with medical therapy, but at some point, they may get worsened. They may because of progression of disease, they get more symptomatic, and then then revascularization should be an option to reconsider keeping them always on medical therapy. So we have to look at the use of interventions with fresh eyes and say consider the patient in itself, or and then consider whether medical therapy or revascularization should be considered. Of course, I'm talking only about PCI. I'm not talking about coronary revascularization that is effective and safe and improves survival. But what is important is not to see them as alternative, but they work together. And even patients who receive a revascularization should be on optimal medical therapy. Thank you very much.
Dear colleagues, if you have any interesting or even controversial comments, please feel free to post them or email them to us at kol@p2pmd.net. We will organize these comments in a special Q&A video next month.